Hi, everybody. Welcome to the Institute for Collaboration on Health and Intervention and Policies lecture series. I'm Dr. Beatriz Aldana Marquez, and I have the honor of introducing our great speaker today, Dr. Heide Castañeda. She is a professor of anthropology at the University of South Florida. Her areas of research include critical border studies, political and legal anthropology, medical anthropology, migration, migrant health, citizenship, focusing on the US-Mexican border, Mexico, and then Germany and Morocco as well. She is the author of Borders of Belonging, Struggle and Solidarity in Mixed Status Immigrant Families, and the co-editor of Unequal Coverage, The Experience of Healthcare Reform in the United States. And her latest book is Migration and Health and Critical Perspectives, that was published in 2023. Dr. Castañeda has also published dozens of research articles on migration, healthcare access for immigrant populations. Her work has been funded by the National Science Foundation, the National Institute of Health, the Fulbright Program, the German Academic Exchange, and the Wenner-Gren Foundation of Anthropological Research. We are very excited to hear her work today. If you could wait for your questions until after the lecture, that would be great. And I hope to hear from all of you after.
Great. Thanks, everyone, for coming today, and thank you for the invitation. Really appreciate the opportunity to talk a little bit about this topic today. I think this is the first lecture in the series this semester, so I'm going to step back a little bit and talk about the issue of migrant health in general. I was thinking about the best way to talk about some of my work with you and share some of the findings. And I actually thought the best way would be to sort of step back and think about some epistemological issues, some philosophical issues around migrant health. So you'll see that basically happening today. Let me start by actually giving you a bit of an outline. So my goal today is I want to, like I said, step back and think about big picture epistemological questions around the issue of migrant health. Why do we study migration and health? What are some common assumptions within each field and between both fields synergistically that we could unsettle or revisit and think about more critically? Then I'm going to move to a few major points around, sort of findings from research projects I've done on migrant healthcare, and specifically on healthcare access in places like the United States, especially the border region, Mexico, Morocco, and in Germany. And then I'm going to wrap it up by providing a set of principles, a checklist of principles for those of you who are interested in migrant health or already work in migrant health or who have questions about migration and health, to help you sort of encourage you to think more critically about this field. And then we'll open up for some questions. I'm actually very excited for the interactive portion of this, so I'll try to keep it as brief as possible so we can interact a bit. So just to kind of set it up, as Dr. Bam just explained, I'm here at the University of South Florida. A lot of my research has been in these four countries: United States, Mexico, Germany, and Morocco. I've provided this slide, this map, to just sort of let you visualize a little bit why these are important sites of study. And you can see the red arrows here, which, some of this is imperfect, and we could talk about that later. These red arrows are showing some of the major migration routes in the world today. And the blue dots are sort of regions where I've done my research. Sinaloa in Mexico, in the US-Mexico border region, South Texas specifically, in Berlin, Germany, and I currently work in southern Morocco on issues of transit migration. So these are all areas where folks are either settling in as migrants or passing through. And I think each of these sites raises really important questions, again, from an epistemological standpoint. So hopefully we'll get to talk about some of that today. Just a shout out, I'm going to mostly talk about these three projects. These are three NSF-funded projects. Two are in the United States and one is in Morocco. These are the ones I'm going to mostly talk about today. I'm actually going to focus quite a bit on the United States because I think most of the people in this audience are familiar with the some of the questions around migration and health in the United States, but I'll do a bit of comparison as well. So let me begin by sort of stepping back and thinking about what this field is. What is migration and health about in general? Why do we study migration and health in tandem? And how can we unsettle some of the conventional ideas we have about migration and its relationship to health? So just to give you a quick example of what I mean, in the United States, we have a very heavy focus on undocumented or illegalized migration that is due to a specific set of policies and laws that we have in this country. But migration and health might look different in other places. So what I mean by unsettling conventional wisdom is thinking about things like the different varieties of migration that exist in the world, and how people's lives are affected at different points in time. It's not a static feature of most people's lives. So we'll talk about some more. And the second question is just one about healthcare systems and how they tend to work well for some populations over others. And some of that is intentional, and some of that is linked to sort of unintended effects of policy, which are also very interesting and important to study. And in fact, in many ways more interesting and important to study, because it tells us a bit about how healthcare policy trickles down from the lawmaking level into everyday interactions with people who are trying to access care. So I want to begin by suggesting to you that migration is a fundamental part of human behavior. It's something that we do as a species. We always seek out better resources and opportunities in response to particular pressures in our environments. That is what we do. We've always done that. And so in that sense, it is a fundamental aspect of our adaptation as humans. But I don't want to imply that it's a natural phenomenon. In many ways, migration is unnatural because it is often due to political and social pressures and economic pressures in a home country that are anything but natural. They're human instigated in so many ways. So in the end of the day, and I will say this too, there's a lot of talk about migration being, on the rise, or there's a lot of almost hysteria in political circles about the rates of migration. In fact, the rates of migration worldwide have not changed very much over the past 50 or 60 years. About 3% of the world's population is on the move. Of course, the percent of the population is one thing. The actual real numbers are quite large these days, especially for folks who are leaving circumstances in their countries that are violent. So we see forced migration incredibly, very much on the rise today. But overall, migration has not increased as a proportion of the population's activities globally. We have to think about migration as a continuum. It's not simply a matter of force or choice. So I'll encourage you later in the talk today to think about the language we use when we talk about migration and migration and health. There are implications for terms like labor migrants or refugees. These words are laden with certain types of meanings and ideas of deservingness. And in fact, in most cases, migration fits somewhere on the spectrum of both being forced and a matter of choice. And these things are not easily separated. To say that somebody has been pushed out of their country because there's a lack of economic opportunities does not imply necessarily that that's their choice, right? Oftentimes we have to think about the fact that they are simply doing what we do as a species, and that is searching out for better environments. And, as healthcare researchers, I think it's really important to remember that migration is not, because it is a fundamental part of being human, it's not a situation that is extraordinary, unusual, pathological. And I think that is one of the fundamental flaws in the study of migration and health, is that we assume that migration has somehow negatively impacted health. And of course it does in many ways, but I think that we have to check ourselves and our assumptions about what it means to migrate. It's not a pathological process, and is also not producing ill health necessarily. And we'll talk a little bit more about that. But my key warning here is that we have to be careful that these assumptions about the extraordinary or unusual nature of migration should not be carried over into our research questions, but rather we should step back and think about it as a more general phenomenon for humankind. So I work with a critical perspective on migration and borders. As was just mentioned, my latest book is actually called Migration and Health, A Critical Perspective. So I'll be talking about that a bit today. Basically what this is encouraging, this book and the talk today is encouraging you to do, is to think about the study of migration and health within a larger set of studies and broader analyses of social inequalities. And most importantly, I was prompted to go down this path through, at this point, decades of study on the health of Latine populations in this country and immigrants from Latin America, recognizing that the scholarship in this area very often points to a few key issues like language, and very often points to health behaviors rather than looking at people's lives within a broader set of circumstances that we talk about as upstream structural factors. And so I want to sort of reorient the conversation to move away from individual level behaviors. Why do migrants whatever eat unhealthy food or something like that, but rather to look at their lives within a larger socio-political context. And that's where this checklist will come in handy when I get to it at the end of the talk today. So all of this is situated within a larger move within public health and health sciences to look at social determinants of health. And even this is certainly not new. This has been going on for decades and has been modified and improved in a lot of different ways. But the general message here is that migration is both a consequence of people's social determinants. So they get pushed out because of things like poverty, inequalities, violence in home countries, but it's also a social determinant in its own right. So many of us have been writing about the fact that one of the social determinants of health is being an immigrant or a migrant. And, that plays out in a number of different ways. But to play that out, you have to look at those large scale upstream structural factors. And I've listed a few here that impact health in particular, such as access to care. That could be lack of insurance, but it could also be a number of social and institutional factors that limit people's ability to get the care they need, including preventive care. It could be their living and working conditions. It could be general features of poverty and income inequality. It certainly is related to immigration policies in a nation and the enforcement practices that go along with it. We'll talk more about that shortly. And then it's also interconnected with a number of other hierarchies related to gender, race, ethnicity, and so forth. So this is sort of the perspective I'm taking here in the talk today. So let me sort of turn to a broader question, sort of a big picture question of what makes somebody a migrant? What is a migrant? What is an immigrant? And I don't have an answer for you. Shocking. I'm not going to leave you with a good definition here, but I do want to encourage you that when you have either as researchers, as you work on research studies using terms like migration and immigrant, or as a layperson, as somebody who's having everyday conversations with your neighbors, to think about what that term means. And the fact that, there's a number of different ways that people enter a country. Not all migrants are unauthorized, certainly. There's lots of different forms of legal statuses, many of which are highly precarious, even though they may be a legal status, right? So if I think of something like DACA or TPS here in this country, these are statuses that are highly precarious, but that doesn't mean that people are undocumented. So we have to kind of parse out what that means in a particular case. People have different notions of settlement. Many migrants I talk to very much intend to leave this, if we're talking about the United States, they very much intend to leave and go back to their home country. They don't intend their settlement to be permanent. Other times they do. And then, of course, many people do move back and forth between their country, their home country, and a new country. And so that has a lot of implications when we say, migrant health. We're sort of very much focusing on the migration piece of a person's lives, but their lives are often very much more complicated and much more rich than that, right? So for me, as a researcher, to say somebody is a migrant, I'm really reducing them to one particular aspect of their lives rather than thinking of them in their own terms. And, if I were to ask them, who are you? They might not say migrant in the first 10 or even 20 words. They might say, I am a daughter. I am a Christian. I am a Muslim. I am an engineer, right? They may have many other ways of identifying themselves rather than migrants. So migration as a variable is something that we put on people as either researchers or, again, in lay terms. We need to look at their wider set of identities and experiences and how they self-identify. So, of course, this leads to the second point, that our experiences are often very highly intersectional, and they change across the life course. You know, someone may consider themselves to be a migrant when they first move, but maybe 2 or 3 or 20 years later, they no longer do. So understanding where people sort of stand on this sort of temporal scale is important. It's really important to me that we avoid reinscribing inequalities through our terminology and through our variables, right? So I think even just setting up migrant versus citizen is again, in some ways doing a bit of definitely a bit of disservice, even violence, to people's identities, right? Because that might not be the primary feature in their lives. They may share something in common with the people that we identify as citizens much more than they would set themselves apart as on the other side of that spectrum. So thinking about how the terms we use matter. This also often comes up in the case of the very term migrant, because in some countries, people with migrant background will be recognized as non-native people through subsequent generations, right? So I'm thinking about the German case, for example, where it is still a very common variable in health research to say person of migrant background, and that person may be 3 generations removed from the time their family member actually migrated. So thinking about how these kinds of terminologies really reinscribe inequalities and set sort of us and them types of situations up in research and in public discussions. And then, of course, it's probably not surprising, the politics of citizenship in this country especially are deeply racialized, and recognizing where all of this comes from and how it is that people are categorized the way they are. You know, so I guess here I'm really talking about categories, right? Who are migrants? These categories are often deeply racialized, and in the case of immigration are often marked by what we call deservingness assessments, right? Just as an example, people may wish to delineate a refugee from a labor migrant because they feel that there is a particular deservingness associated with one category over the other. And I'm not here to say there isn't, but I want to remind you that there's a spectrum of force and choice going on with migration. And so even labor migrants often are forced migrants, depending on the particular situation. I'm not going to belabor this slide much, but I did want to speak to the issue of phases of migration, because that comes up quite frequently in migrant health research. People like to talk about phases of migration. I tend to work on healthcare access, so I'm really looking at that sort of middle, lower arrival and integration phase, right? That's where most of my work is situated. But people do like to talk about these different phases of migration. The reason I wanted to show you this slide is because these are not as clear cut as they might seem on a black and white graphic. People, not only do they return to their home countries frequently, but they often migrate to other countries along the way or after they've arrived in a place. So, this type of schematic is really helpful to think about the different time phases in a migration process, but it's not very good at capturing people's lived reality of that process, because it's much more messy and complicated than this schema might lead us to believe. But you can see here that there's different health impacts associated with things like a journey versus language and cultural integration in a new country and things like that. So certainly there are different moments in time where vulnerabilities emerge in different ways. I want to introduce a couple other concepts here and just sort of put them on this graphic for the moment, but I'm going to go through each one in turn. But there's sort of key factors that relate to inequities in health and healthcare access for immigrants. And I want to start with the first one, which is legal precarity. It's probably not surprising to folks that this is a major way in which immigrants experience unequal treatment in our healthcare systems through their access related to legal status precarity. And precarity in this case, I'm defining as life without the promise of stability. This doesn't apply only to undocumented folks. Most immigrants are in some sort of either for their entire lives or for a certain duration of time, experience sort of waiting process on them and their both usurpation or appropriation of their time. This has also been written about, I should mention, not just in the case of immigrants, but for the case in the United States of welfare recipients. There's a lot of literature on how their time is stolen from them through a number of often unnecessary bureaucratic practices, right? There's a lot of waiting that goes along with being poor in the United States, waiting for services, applying for services, waiting for decisions, being out of control during all of that time. And so this is very much a parallel with the experience that many migrants go through, even beyond, as I said, undocumented folks. This is an important social phenomenon that we find as a part and parcel of the migration process. But we can also turn it on its head and turn it into a very powerful analytical perspective to think about issues of bordering, of belonging in the ways that state power is enacted, how people are included and excluded, whose time matters and why, right? And just how social relationships function using that analytic power of the condition of waiting. And of course, people don't always just accept it. They often resist or even incorporate these ways of waiting into their lives. Insecurity, not surprisingly, is a major factor for most migrants. And most recently, we've been doing a lot of work here in Florida on the emotional and mental well-being of immigrant youth. And this is one major issue that we've zoomed in on, is the interplay between economic insecurity and emotional insecurity that people have. And of course, it again doesn't necessarily relate only to undocumented folks, but precarious relationships are a key feature both of this waiting process, but also just of being in limbo in one's life. In addition, migrants do have an added feature of having transnational relationships often that, for various reasons, may be precarious and create lots of stress in their lives. Many migrants, I would say almost most migrants I've talked to, experience periods of loneliness. They experience lack of social support structures. And increasingly, we're looking at the health impacts of things like shame. Many migrants will not reveal to their families and friends back home what the real circumstances of their lives in a new country, right? They often will paint a pretty picture or take pictures, literally take pictures next to, landmarks and fancy cars and, make it look like their life is well. But on the inside, they're often struggling to find adequate employment and are ashamed to talk about these issues with folks back home who have placed so many promises on their journeys, right? So that's a big issue that people struggle with. Racialization processes is another major factor, especially here in the United States. But I will talk really briefly about some of my research elsewhere, but in Morocco as well. Most of our work in Morocco is with sub-Saharan migrants, and there are particular ways in which race plays out in North Africa that affect migrants' abilities to find belonging in those spaces, right? And I'd be happy to talk a little bit more about that in the Q&A as well. But, racialization practices in general are these socially constructed meanings that are associated with specific racial or ethnic groups, and that structures their access to power, privilege, and health promoting resources. And of course, they have a major role in placing stress on folks when it comes to mental and emotional health inequalities. That's something, again, hearkening back to our research here in Florida currently. And then finally, I wanted to mention the term compounded vulnerability, which is by Caitlin Patler and Gonzalez. They talk about this as the synergistic interaction between legal status precarity and other layers of state violence that produce neglect or exclusion and aggravates already difficult experiences. So their work was particularly looking at incarceration and how incarceration interacts with things like legal status or poverty to exacerbate on an exponential scale people's vulnerability and familial vulnerability. And so we can use this as another term to look at legal status and how this exacerbates immigrants' vulnerability. It's not just like additive layer upon layer, but it's much more of a exponential type of vulnerability that happens when your fundamental life is precarious and insecure because of legal status. So just back to this research sites, I wanted to remind you about this map. I'm going to actually focus mostly on the work here on the US-Mexico border, but I would be happy to expound a bit on the other areas during the Q&A, which is for the purposes of time. And I know folks are probably most aware of what's happening at the US-Mexico border. I want to talk a little bit about my work in South Texas on mixed status families. So the book that this research resulted in was called Borders of Belonging, and it looked at mixed status families, arguing that the mixed status family is a primary feature in the United States in the contemporary experience of migration in the United States. Some 16.7 million people live in mixed status families, including 4.5 million US citizen children. I think that's really remarkable. In some parts of this country, particularly where I did the research, 1 in 10 people are undocumented, which makes it highly likely that pretty much everyone in the community knows someone who's undocumented or lives in a mixed status family. Schools in this region regularly have US citizen children with undocumented parents. They have ways of, handling things when it comes to this level of common shared experience. But the point of the book, and the thing I want to emphasize here, is that when the state constructs a person as quote unquote illegal, when it rejects their ability to get a legal status, this does influence opportunities for their entire family and the resources that they can access, including healthcare resources. So I'll talk about that for just a moment. So mixed status families, I found, have stark differences in access to medical care. Let me stop there. I'm not talking about the undocumented folks. I'm talking about all members in a mixed status family, right? So to give you an example, I brought a quote by Luz here. She's explaining how she is hesitant, like many other undocumented folks with citizen children, to enroll their kids in programs that they're eligible for, things like Medicaid, CHIP, and WIC. So Luz says, I didn't want to ask for WIC or anything because they say that this could affect you if you want to fix your status later. The social worker told me, it's not for you, it's for your son. But I'm afraid and I don't want to have it. Right? So I wanted to use this quote for just a moment to think about the issue of healthcare access, right? So here you see a number of the themes that I just mentioned reemerging, this idea of legal status precarity, of insecurity, of waiting, and of compounded vulnerability, right? So Luz, in this particular case, is anticipating that somewhere down the line, if she waits, somewhere down the line, an opportunity will emerge for her to legalize her status. And in fact, that's not unrealistic. That does happen for many folks. But what they know is that they can't have any sort of blemish on their record. And so in order to avoid being seen as a public charge, someone that has taken any types of services from the government, in this case, she's refusing to even take WIC for her son, who is a US citizen. Now, WIC does not count against folks who are regularizing their status, but some other forms of government assistance do. So it's not just simply a case that she's confused here, right? Social workers frequently reported that there are a lot of people, who kind of are worried that maybe it doesn't count against you today, but it might tomorrow. And in fact, that was the case during the Trump administration, that some of those rules were changed, that the public charge regulations were changed to include a wider variety of services, including in some cases, nutritional programs and medical services. So you do see that while it's not currently the case, it is true that these things might in the future affect someone's regularization. And so you can't blame Luz for being cautious. At the same time, of course, we see that her son is not able to take advantage of programs that he is eligible for as a US citizen. So just trying to show you how this plays out in a mixed family situation in which, the US citizen also is impacted by state determinations about a person's legal status. In addition, this book really focuses on, again, the US-Mexico border, which is heavily militarized, and I can talk more about that in the Q&A if you're interested, but suffice it to say there's a lot going on here in terms of highway road stops. People are frequently inspected while they're driving or working or taking their kids to school or going to church. People recognize that there's a lot of law enforcement activity in the region related to border militarization. So this has implications because people often will avoid medical care for that reason. They don't want to drive. They may worry about running into police or immigration officials, but they also often will, this also impacts their health in another way, and that is through worry, the stress of worry. And it's not, the takeaway point I want to share with you here is that it's not necessarily the stress of worry of their own deportation. Getting back to mixed status families, it's often the potential for deportation of their family members or even people in their wider community. So these are communities, again, where 1 in 10 people are undocumented. So to have a neighbor who might be deported or face deportation, it has ripple effects on the entire community, right? And so, so people are sort of embodying a lot more stress around immigration enforcement than you would in perhaps in other parts of the country, but certainly in other kinds of communities that don't have the same legal status precarity. Increasingly, there are studies coming out in public health where they're showing that there are actual physical effects on the body, increased BMI, increased heart rate, things like that. Increased systolic blood pressure, things like that, that indicate that people are living under constant stress in these communities, right, because of immigration enforcement. And so that's a very real health impact on both on the body, but also on emotional and mental well-being. So I'm going to stop here and just give you a quick takeaway, how this compares to other settings that I've worked in, and then I'm going to move on to that checklist and start our Q&A. So when I compare migrant healthcare access across these different sites that I work in, we've already talked about the US situation, but let's bring in Morocco and Germany as some counterexamples. As an anthropologist, we often like to use comparative cases to kind of see what sticks out in particular national settings, what are some patterns that are common. And these are the sort of the 5 pieces I wanted to just briefly mention. One is immigration policy, right? Each country sets the terms of how it is engaging with people who move to their country. And some of them are much more friendly towards immigrants and some are less friendly. And as I mentioned earlier, it often depends on these notions of deservingness. Things like, does a refugee have more right to access healthcare than someone who comes as an undocumented labor migrant, right? So immigration policy sets up the terms of, it sort of sets the stage for a lot of this. I just mentioned notions of migrant deservingness and how that interplays there. Certainly insurance is a big one, especially here in the United States. One thing that I've always said is that here in the United States, it's actually easier to get healthcare access if you're undocumented than it is in places like Germany, right? In Germany, it has a universal healthcare model. It does also have private insurance, but it has a universal healthcare model. So it is not only unlikely or uncommon, but completely unheard of that somebody wouldn't have that somebody wouldn't have insurance, right? And so when somebody shows up to the hospital or a doctor's office and doesn't have insurance, that automatically marks them as being undocumented in some fashion because of the universal healthcare model. So what I'm trying to say is because the United States, well, what are we, 14 years after the Affordable Care Act, the United States still has incredibly high numbers of uninsured folks. Migrants are able to access services much in the way as other uninsured folks. Often that requires, paying something on a sliding scale basis, or accessing charity care, or finding other ways that don't require you to have an insurance card. This is quite different in a place like Germany, where there's just simply no way to pay because everybody has insurance. There's no mechanism for doing that. So I don't know if that's the bright side, but I will say that because migrants who don't have health insurance typically fall within the ranks of the rest of the uninsured, it tends to be quite easy for them to access care in the United States. What is not easy for them is how to pay for it. And on the flip side, I should also say that not all undocumented migrants don't have health insurance. In fact, many do through a variety of mechanisms. Folks like DACA recipients are able to get not always, but sometimes healthcare insurance through their employers, even if they lack a stable immigration status. So, looking at that a little more closely is important. And then finally, thinking about, how robust a healthcare system is to take on folks who may be uninsured, or, I wanted to hear kind of briefly contrast it with Morocco, where there's a flailing healthcare system. Everyday Moroccan citizens are not able to access healthcare in a very regular fashion. And a lot of that has to do with brain drain. A lot of Moroccan physicians, nursing staff, and researchers leave the country once they're educated because of opportunities in places like Europe. So in North Africa, you see brain drain really impacting the healthcare systems. And that means that there's inadequate healthcare access for the entire population, including migrants. So it makes it quite much worse for them in that particular situation. So you can see there's a number of different factors here. Certainly not enough time to talk about them all here, but I wanted to lay out a few counter examples and think about how we compare this across different settings. So in the last few minutes, I want to turn to a checklist for a critical approach, and then I'm going to end and open it up for Q&A. So a critical approach to migration and health. I've got a few different points here that I want to make, and I'll elaborate on each. The first point is that it doesn't look at, for ill health, causes of ill health in behavioral or cultural factors, right? We're focusing on these structural concerns. We're looking at policy. We're looking at inequality that emerges through larger historical and political processes. That's an important factor here. If you're looking at those behavioral factors and not situating it within that, then that can't be, that's not a critical approach. That's a very individualistic way of looking at an individual level way of looking at certain health issues. A critical approach is also explicitly attentive to social, political, and economic power and how it is exercised and distributed in our societies. That's why I brought up the issue of, the insurance systems and the healthcare systems in general. These are big picture factors that really impact how people are able to maneuver in a society. A critical approach to migration and health is also going to acknowledge that migration is the result of broader colonial and globalization processes that continually displace populations. Again, back to the issue of voluntary versus forced migration. These things are often a non-issue when you live in a place where people are being displaced through larger economic forces. People may be pushed out through that as well. A critical approach is going to look at multiple diverse and intersectional standpoints about migration and reject those binary oppositions, things like citizen versus migrant. That's not a particularly useful way to set up an analysis of a migration situation, but rather to look at how their lives are very complex and tangled and intermediate in their experiences moving through space and time. And trying to find a way to capture that. And again, we tend to focus on, when we say migration, we often lump that with undocumented migration. And I apologize that I've done that for quite a bit here today, just for purposes of illustration. But again, people's experiences are much more diverse than that. We have to find language and ways of creating variables that can capture that. And I've already mentioned that I don't really believe that it's a great idea to split migration into distinct phases. It implies that they are unidirectional or linear or discrete. And in fact, people, move around a lot and then they move further. And, again, from an epistemic perspective, it implies that there's a really distinct difference between here and there. And oftentimes there is not, especially in our globalized world today, where we're so interconnected. A critical approach would avoid studying migrants simply from the perspective of citizens. By saying the word migrant, I'm already creating a standpoint there of, I'm creating a problematic standpoint there where I'm designating someone else as a migrant, right? And I know this sounds pretty basic, but it really has huge implications on the kinds of research we do and the way we use our terminology. Certainly accounting for the researcher's positionality and our own roles in creating that inequality through the terminology we use and through the very research questions that we design, I think is really important to recognize that. Not to say that you can't pick research questions that you'd like to do, but certainly recognize how that is reinforcing some of these unequal power relations. As I started off saying, migration is not abnormal, and sedentism isn't the norm, and I could talk about that for hours. I'm currently working with indigenous folks in North Africa who have a long history of mobility. They're not sedentary, and so I think that's another way in which we sort of problematically set up our standpoint as if something were the normal or natural way to be human, and it's certainly not. A critical standpoint is also going to trouble the idea of a border as a fixed object, right? Borders are not lines in the sand. Borders are actually created through practices of inclusion and exclusion. So by our very everyday social practices, we create borders, right? It's not simply a physical border, but borders carry over into all these different spaces, and borders are increasingly electronic as well, right? And I think that's important to remember. Critical approaches recognize human freedom of movement as fundamental. And I've said that before, that we shouldn't consider it unusual or pathological. Related to this, I think that there's a tendency that we are probably all guilty of in some way, to think that the life in our country is a great life, and migrants desire to come here. And that is not always the case. I have found in many cases, both here in the US and working in North Africa and in Europe, that sort of underscore that these are colonialist notions, that we think that people really want to come here and live, and they think life is really better here. And in fact, oftentimes the choices are made for very different reasons. So what I'm saying is that we don't need to posit the idea that the global north, whether that's the United States or Europe, that's the primary or the preferred destination for migrants. Oftentimes they choose it for other reasons, not because they necessarily want to go there, right? There may be other factors as well. Avoiding violent and militarized terms and dehumanizing language, I think that's a pretty obvious one. Even the AP style book, like 15 years ago, rejected the use of the term illegal for describing a human being. So words like that, even to this day, the term alien is used in government processes to, these are dehumanizing words. And I think as researchers, we should not necessarily, we should not adopt those same terminology. And that often is difficult to do depending on the kind of work you're doing. If you're doing statistical work, you're often relying on government sources and terminology. But I think being very critical and cautious of that is important. And just to sort of wrap it up, I think that, there's the three last points I want to mention, which is that critical approaches recognize that it's not about the migrants' countries of origin. It's not about because someone came from Honduras or Haiti or something, that there's something intrinsic to their health behaviors, but rather it's often the inequality and structural constraints in the host country that are impacting the health issues that we're looking at. And I think that's the really critical point, is not to always say, and this is where I think sort of decentering migration and health is so important. It's not because they're a migrant and they have other experiences that are somehow pathological that they're bringing with them, but often it's the pathological conditions in the host country that we should be looking at. And so I would encourage you to sort of think about it in that way, rather than always pointing at like what's going on, what's the expression of that illness in the country of origin. I've already talked about the fact that it's not just migrants themselves. In the case of mixed status families, other people are affected by migration, healthcare access and health issues. But overall, a critical approach would seek to eliminate those health disparities and to uplift migrant populations. So in conclusion, I want to share a quote, which is that migrants should be considered, or are considered, canaries in the coal mine, and how well we treat migrants in terms of healthcare access is a barometer for how well we treat other marginalized populations. There's a lot of parallels here. A lot of the things that I just said about migration, we can take and apply to other social groups in our society as well. And I think that's the point, is to denaturalize the fact that migration is a particular type of variable, but rather look at it in its broader social and economic and institutional sort of implications that come along with it. So I'm going to end there. I would love to share with you some Q&A and have some interaction in the last 15 minutes. And yeah, I'll open it up at this time.
Thank you so much. I think a lot of what you said I think presents a lot of value about how we think about migrants and even the terminology. And I've been guilty myself. I think I'll start with some my questions, and then we can open it up to the crowd. So when I was hearing you discuss kind of the situation with Luz a little bit, it makes me think about like life course for the second generation and even like the third generation. So when it comes to those disruptions, especially because of like the political atmosphere or the precariousness of like DACA, like when, I'm thinking about like when it was on and when it was off and people weren't able to submit. How have you seen any kind of issues in your work, or can you speak a little bit about that, of like health and the life course of people who migrated into the United States?
Yeah, thanks for that. That's a really great question. So that's some of the work we're doing here in Florida right now, looking at DACA recipients over time. We've been working with the same cohort of folks for the last 5 or 6 years, I think, 7 even, and looking at precisely those things like, DACA's on, DACA's off, and people's, continued insecurity and precarity, and what that does. I think to speak to the life course issue, what we found is that a lot of undocumented young adults, those who are usually eligible for DACA, they experience a lot of disruptions in their sort of what we might consider, sort of traditional moments of becoming an adult, whether that's, going to college, having romantic relationships, social relationships, all of these things get disrupted. Getting a driver's license. I mean, there's so many ways in which people's expectations of how their young lives should unfold are disrupted because of the immigration status issue and the precarity of the political situation. So, that might not seem hugely significant to some folks, but for many people it is. Many people want to go through traditional life milestones and are unable to. And we found with DACA in particular, people would start and stop college because they weren't sure, like, can they finish in time? One particularly poignant quote I remember is somebody said, "I have an expiration date on me," right? This idea that, like, whatever it is, August 2024, they had this expiration date, and it was like stamped on them, right? That they only had that much time to finish college or to get married or something, right? Something in their life had an expiration date. And I thought that was really poignant. It's hard to live with that, right? That really weighs on people's emotional, physical, and mental well-being. So, yeah.
Thank you. I'll open it up to our lovely audience. So if any of y'all have any questions, or if you feel a little shy, you can write it in the chat. We can keep it going. If not, I have more questions, so it's great. I'll ask my other question that I had. So I'm thinking about also like the election year, and I know that the Trump administration's plan is mass deportations, but I'm also considering the local level, right? And how that role of policies has a huge impact for migrants and their access to resources. So can you talk a little bit about how you've seen that in your work?
Yeah, that's a fantastic point. And I think we often don't pay enough attention to the local level. A few years ago, there was a move to do things like sanctuary cities and that sort of, creating welcoming, or on the contrary, creating unwelcoming environments for migrants. We've seen that in both cases. We've seen both sides of that playing out across the U.S. and the same within the same state often too, right? Certainly here in Florida, that's the case. So yeah, I think we don't pay enough attention to the local level, and the fact that at the local level there are short-term, immediate, and impacts that are so important. At the federal level, mass deportation, changing immigration policy, sure, that's important. But what's happening in people's day-to-day lives is happening here at the local level. For example, here in Florida, we have new laws that sort of impact people's abilities to either, for example, getting driver's licenses, or being able to be stopped on the street and asked about their papers, right? There's a number of states and local entities have invoked these kind of laws, and that really creates a real chilling environment for immigrant families. And again, as a reminder, not all immigrants are undocumented. Just to your point, what we're finding is it's not just the undocumented folks that are feeling the effects of that. People who live in municipalities or states where this anti-immigrant legislation is being introduced, generally feel that they're in a hostile environment for people of their nationality, race, or ethnicity, and it has nothing to do with necessarily with the immigration status. So it's a highly politically charged issue right now. I guess my message is that it spills over beyond the folks who are undocumented or living in this country without authorization. It spills out into our communities and creates an environment of insecurity and disrespect for a lot larger set of folks.
Excellent. Okay, we have a question in the chat. Kim asks about any suggestions for recruiting undocumented individuals into research studies.
Recruiting undocumented folks into research studies. There is no good formula for that. I think my advice would be, it takes a while to gain trust in communities. You have to show up. You have to be honest. You have to be very clear about your positionality and your goals for research. I find that partnering with immigrant organizations has always been a great place to start, but often those organizations are tired of dealing with researchers and students and things like that. So you have to really convince them that what it is you're trying to study is of value to them too, right? It's got to be collaborative in that sense. And I think, again, showing up and being honest is really key. I would never have recruited undocumented folks if I hadn't been to a gazillion events that organizations put on, and marches and dinners at people's homes. Like, you have to be present. It's not enough just to send an email or phone call or something. You have to actually be present for a very long time before folks buy into what it is you're trying to sell them. And that's, if it's a research project, you need to be very upfront with their participation and what it's going to bring them as a benefit to. It's a community-based participatory model that's going to work best in these cases.
Excellent. I guess if nobody else has one, my final question. So you're talking about a little bit about the U.S. Mexican military formats, right? So I was wondering, like, if you see any like differences or similarities, or like, when you're looking at like Morocco or Germany, because frankly, I'm a little bit ignorant when it comes to the international part. So I would love to hear you kind of discuss a little bit about that.
Sure. Which part particular? Like,
I guess like the militarization here of the use of technology, but like it's kind of a selective enforcement, right? So I guess that's like how I like picture it a little bit.
Right. Gotcha. Well, I will say this, the reason I chose Morocco, other than, I mean, I have personal reasons. I'm actually in Morocco quite a bit, but the reason I chose Morocco as a field site is because it parallels the Mexican situation in a lot of ways. So Morocco serves as a quote unquote buffer to the European Union, and the European Union sends gazillions of, that's not a good term, billions of dollars of equipment and resources to Morocco to strengthen their navy and their border patrol in order to, sort of help prevent people from going to Europe from sub-Saharan Africa. So in many ways, it very much mirrors the situation in Mexico, where the U.S. has poured lots of money into the Mexican military and border patrol to prevent people from coming through the Mexican-Guatemalan border, for example. So you see a lot of the same things happening, where it sort of becomes the police, the border guard of the other country. So Morocco as the border guard, or they actually say the gendarme of Europe, right? And similarly, Mexico is now capturing a lot of folks, not capturing, is now receiving a lot of folks who are trying to come to the United States and kind of get stuck in Mexico. So this getting stuck in Mexico is very similar to getting stuck in Morocco. And so there are a lot of parallels to these two processes, and that's why I was really interested in looking at it. It plays out in very similar ways, except, as I said earlier, the Moroccan healthcare systems are much more fragile, so that when people do end up staying there, it's increasingly difficult for them to get medical aid when they need it. Yeah.
Fumi had a question similar, but oh, Christina has her hand up, so
Yes, thank
yeah,
you.
go for it.
So thank you so much. This was a great presentation. Thank you for sharing your research. And I'm a clinician scientist. I'm a physical therapist and work with Hispanic and Latino communities. And I just had a question referring back to, I think you were in some of your critical points, you were talking about the socio-ecological model and how really our attention and our focus should be at these policy levels, these structural levels of change to improve health and wellness. And so I absolutely understand that model, and that's where our greater level of change will occur. But as a frontline, like healthcare provider and researcher, I am paying attention to these individual behavioral issues and cultural issues. And I would love for you to just clarify those points that you were making and how healthcare delivery, if it can and should be interacting on those levels as well.
Yeah, no, that's a fantastic point. I think there's a huge tension here, right? I think when it comes to everyday practice and especially clinical practice, it's just hard to implement those perspectives. It's generally impossible to implement those perspectives other than reflecting on the fact that the immediate issue that is behavioral and individual may be situated and couched within this larger, but then how do you act upon it? I don't have a great answer there. I think the key is that the awareness on both ends. I think a lot of this came out of experiences where people felt, that there was some victim blaming going on, that people were attributing, like, I don't know, poor diet or whatever to people's individual behavioral choices. So saying, well, it's not that, they're situated within these larger, okay. But as a clinician, those are issues that are hard to address. But I think that the takeaway, the cautionary tale is just sort of like how in the interaction you kind of recognize those issues as well. I don't think that, clinical practice is always well suited to address those big picture issues, of course not. So it's a big tension. It's a big tension. And I acknowledge that. I think we just learn from each other. And I think, the key here is just sort of recognizing that both things are happening simultaneously, and avoiding those negative implications. Like I said, avoiding putting the burden on an individual because they've somehow made a poor choice, right? I think that it really comes down to the communication style. Yeah. But thank you. I appreciate that. It's a great question.
Thanks.
All right, y'all. We will conclude today's lecture. Thank you so much, Dr. Castañeda, for your work and your discussion. I appreciate everyone in the audience. If y'all want to be able to look at the lecture, Josh did put a link there for the YouTube link, and hopefully y'all will look through future presentations in this lecture series. All right, thank you so much.
Thank you all for coming today.
Thank you.
Yeah.